Please welcome to the stage Clint Flanagan, MD, founder and CEO, Nextera Healthcare.
Welcome back from break, everybody. We're in the fourth quarter here, almost at the finish line, and that's just the finish line of this RealWorks event, and then we'll be going to Red Rocks a bit later. Awesome to see three healthcare tech CEOs here really trying to solve and help enable us as we're taking care of patients. Many in the room that do DPC already use these technologies, or some that are a little similar to it, and it really helps make our days more efficient and empowers the doctor-patient relationship. We need a whole bunch of people in this boat moving it forward and realize that a lot of these things just aren't within the wheelhouse of a physician, so it's great to have tech partners like those that are here to help us out in this mission to take better care of people and have a model that works better for doctors and patients. We've heard a bit today already about employers and how employers are moving away from the status quo, looking at plans and or instituting plans that provide better care, comprehensive benefits, and actually oftentimes will save them some money. I'm looking forward to our next panel that's going to talk about reinvented health plans. Give a round of applause.
Please welcome to the stage Cedric Kovacs-Johnson, founder and CEO, Flume Health. Nick Soman, founder and CEO, Descent. Olivia Cameron, co-founder, Poppins Health. Moderated by Beth Holmes, head of network development, Hint Health.
Hi everyone, how's everybody doing? Second day, afternoon lull, but I don't hear it. I hear a lot of energy here for the health plan session. Okay, so you all have been reimagining primary care. You've been doing a really excellent job just getting rid of what was broken and doing something new. What if an employer came to you and said, I hired my 50th employee and now I need to get an ERISA compliant plan. Give me a whoop whoop if you can explain ERISA to somebody. All right. It's really hard. It's too hard. It's too hard for most of us to understand, even those of us with health plan or employer experience. And for employers, it's really easy to stay in the status quo when it's difficult to switch. So I think right now, when we're pairing DPC with health plans, we have two options. Go with the traditional plans and pair DPC, which is difficult and bad, or create something new and innovative around DPC, which will be difficult, but excellent. So I'm here with three people today who are trying to do just that. So I'm gonna turn the stage over to them and let them introduce themselves and tell you a little bit about the new health plans that they're creating or enabling. And I'm gonna start with the veteran, Nick.
Hi, everybody. Can you hear me? I see some friendly faces in the audience. I was here in 2018, and I got on stage, and I swore a lot, and I walked around like this. I had a bright pink shirt on. I sort of knew what I was talking about. I really appreciate your patience and helping us figure it out at Decent, because it's a few years later, and we know a little bit better what we're building. I come at this pretty honestly. I'm the child of two primary care doctors who were working in primary care for Group Health Cooperative in the Seattle area for about 30 years each. And I remember being 12 years old the day my dad came home and told me about as disillusioned as I've ever seen him, that he didn't think that his counterparts on the insurance side of group health cared about the patient. And that conversation led me to not become a doctor. And so I started Decent to try to put DPC at the center of the insurance relationship, because I wish DPC'd been around, because my parents might not have gotten so burnt out. I'm gonna be talking about what we do and what it is, but I'm Nick, and it's really nice to be back.
Great, Olivia, you wanna go next?
Yeah, so I was not stopping around a couple years ago. I'm Olivia Cameron, co-founder and chief product officer at Poppins Health, where we're building the only health plan you'll ever need, starting with a product for small businesses, and very, very excited about DPC. We're baking in DPC into the actual plan design, so really excited to be here and meet all of you.
Hi, everyone. A couple familiar faces here. I'm Cedric, CEO, founder of Flume. Flume is the orchestration layer behind the scenes of running a health plan. So anything you need to do to be a health plan is actually outside of the realm of being a doctor. You have to be able to pay claims, you have to send ID cards throughout the country, you have to be compliant with all these local laws. And we don't think you should have to be excellent at that to be building excellent health plans. And so Flume is a platform on which you can go from concept to live health plan in about 6 months. And in 2022, we're actually closing a new health plan roughly every 30 days. So there's this wave of companies like Decent, like Poppins, who are saying, we have a new approach to the world. We're going to go compete with the BUCA with our new model, and it's going to go after a very specific population in a specific way. Yeah. And we just want to power them and let them get to market as quickly as possible.
Awesome. So Nick and Olivia, why DPC? Why did you choose DPC to be the core of your health plans?
You want to take that one first?
Sure. So for us, DPC, very much, we've talked a lot over the past couple of days around the benefits of DPC in terms of experience for members and as well as for providers. I think really, really believe in that. For us as the health plan as well, see a lot of opportunity to actually, again, deliver on the experience portion of that, but also help really us, like Poppins, we sell self-funded plans, and we are the stewards of plan assets. And so for us, this is another way in which we can not only deliver on experience for members and really become a true partner for providers, but also help lower unit cost of healthcare for both the employers and our members, your patients.
We want to work with DPC because it works. And I'm going to give a couple numbers. We're able to save employers about 35 to 40% while offering a comprehensive ACA compliant plan where every member is seeing an individual specific DPC doctor operating in a real, not bastardized DPC model. And that is causing us to realize these downstream savings. This is not hypothetical. Like you heard Dr. Mark talking about this, the folks over at One Medical, you're seeing them make moves in that direction, which is extremely exciting. And it works. And it works not only from a cost containment standpoint, but also a promoter score standpoint, which is like customer satisfaction. We have a net promoter score of 79 on our plans versus an industry average of 19. And I want to take credit for it, but I won't because it's mainly the DPC relationship. We stand in the background, we speak when spoken to, we make sure the members do what you tell them to do, but it's really putting that doctor-patient relationship at the heart of the healthcare that works. And I think the other reason to be a little bit more human about it, we came in 2018 and you told us what to build. And I like interactive panels, so I'm gonna make this one a little bit interactive. I know there are some DPCs in the audience. If you're a little tired after lunch, bear with me, it's 1 minute. Raise your hand if you want more members. Okay, keep your hand up if you would rather see patients than do recording of insurance notes. All hands stayed up. Keep your hands up if you want to keep what makes your practice unique and get paid your fair rack rate. That's what you told us to build, and that's what we built. And I couldn't be happier about how it's working.
If I can add just one thing, from my point of view, you guys are doing the real work. You're conceiving of these new plans. From our point of view, for better or for worse, in the United States right now, your health plan is really the one calling your shots in your outcomes in your healthcare journey. It doesn't matter how great your doctor is. If your health plan is putting a stop to that care, they're not approving that next specialist appointment, that care is incredibly hard to get. And I saw this firsthand when my little sister was going through a major brain surgery for epilepsy, taking 18 months just to get through approvals with an unknown Illinois-based massive health plan. But the point is right now, if you get the DPC model folded into the benefit design, you can underwrite that appropriately. All of a sudden you're seeing a continuity between the people who can decide where you can go, right? And the DPC doctors who actually understand the patient at a ground level and removing kind of the insurance as the check and balance on the doctor to being in many ways folded into the same model with the same incentives. That for me is the promise.
I want to agree with you while disagreeing with part of what you said. So I think you said, the insurance is calling the shot. And that's sort of like saying the government can decide what you eat for breakfast. Like, it's true. It's hypothetically possible that could happen, but you don't want them in your kitchen. They don't want to be in your kitchen. It's really a problem if insurance is calling the shots. And I think our hope is that what we're seeing Certainly it's what the members want. It seems to be what the doctors want. They're not hating us the way that they hate so many of the BUCAs, because it isn't about having that third party that's in the middle of your care. And so I think change can only come if the insurance really puts itself second to that doctor-patient relationship. And I think you agree with me ultimately, but I just like that analogy.
To be totally clear, I think that's right. I think it's unfortunate that today, if you're a patient, you call your insurance before you do anything.
Yeah,
that is
DPC
the entry
first.
point.
And Nick,
And I think you need new models that complement DPC, are not just DPC playing alongside and hoping that you eventually get the insurance to come along.
Yeah, and I'm going to focus on one word in terms of the health plan coming second. I think the way we think about it is that really most of what you just said, but we actually really want to work with DPC because I think, again, all believe in the value of DPC, but unless the downstream network is also leveraged effectively and the member is going to the provider that's going to be covered and that also is reconciled with where their primary care is sending them, then it falls apart. So I think it's actually not necessarily second, but actually in partnership with the health plan and primary care.
Yeah.
I think it's in partnership and second.
I want to get to some of the questions that were actually prepared for the session, but I want to follow that train of thought a little bit, Olivia. How do you work with DPC practices to harmonize the rest of the plans that you're building without creating a lot of burden on them?
Yeah, so the way that I would say our downstream network is, it's something that's very dynamic. I think it's ever evolving. The way that we've approached it so far is that with our DPC partners, we have some perspective. We have a lot of information in terms of clinical quality of certain providers, what our billing practice is. So is a person going to go and get balance billed? Is it going to be a really shitty experience? And so we want this bidirectional feedback where we can give that to our DPC partners. So at the point of referral, they have that information so that they're not only sending the person to someone that they trust or can put a stamp on, but actually someone that is going to deliver on continuing the experience for them as well as not create a financial burden.
Yep. Nick, do you have anything to add there?
Yeah, sure. What we learned when we started going out and talking to DPCs is that some of y'all have people on your panels who don't have insurance. And that means that you become the de facto quarterback for when they need care that's outside the primary care setting too. And we've leaned into that. So when we come to your area, and I have some really exciting news on that, we're going to talk to you and sort of say, where do you refer? Who's good? What do you feel good about? And if we can bring those folks into the network, that works better for everybody because it's comfortable and we know that they're good. But we also know from talking to DPCs, they don't always know who's good, where's the high quality care, where's the high value care that's in my area. And we can bring that data. And we encourage everybody to audit our data, help us understand why we're making the recommendations we're making, because we want to make sure we get it right. And so the opportunity for us is to pay you your rack rate, to send you members, and then when they need that care outside of the primary care setting, we'll help you figure out where to send them. And what's really cool is that they actually want to do what you tell them to do. That's the whole side of this we don't talk about from the patient's perspective. Nobody wants to hear from their insurance about where to go. They want the opposite of that. And so for us at Decent, to just put ourselves in the position of going, hey, we already know you talked to Dr. Ben. Dr. Ben Aiken is our VP of Health, so I'll use him as an example because he's a practicing DPC physician in North Carolina. We got to make sure you actually do what your doctor said, and that part really works. And I think to the extent that we can show up and reinforce the things that you're doing so you can focus on patient care, everybody benefits.
Yeah.
I'll just jump in quick. The entire health insurance model starts from a place of low trust, right? Every interaction at a primary care doctor, any doctor, results in a claim. A claim is you had a car accident, it was unexpected, now we have to figure out who's owed what. However, most of what happens in a DPC office is highly predictable, and it's actually the right thing to be doing, and we should fold the benefit design and the authorizations all the way to prior auths around what does this primary care doc think should happen. You know, all of these constructs that we've had in insurance can start to go away in these, or a lot of the more harmful ones can start to go away.
One way we've seen to really put that on nitro, you know, early on we were selling to small businesses and we were partnering with DPCs, and some of the DPCs started coming to us and saying, we're small businesses. I want to offer something to my staff I have been unable to hire somebody to join my practice because I want to be able to pitch something like Cedera, but they have a dependent with cancer. We've heard that story a ton of times. So we started signing up DPCs as customers. And to be really candid with you, I was a little nervous when it first happened because I said, shoot, if we can't get this right for them, they're never going to refer us out. They're never going to put us in touch with their broker partners, with their employer partners. And it took me a minute to realize that was exactly the sort of clear feedback that we needed and that we wanted. And now it's really excellent because we can come to DPCs and say, hey, we want to send you members. That's a pretty good trade. And if you want to talk about, a full wrap option that's ACA compliant with the employers you want to serve, you can do that. But we'd also be happy to offer a health plan for your practice if you want. And a large number of them are saying yes. And I think that keeps the onus on us where it should be to get it right.
Yeah. So putting on your provider cap, none of us have provider caps, so tell me, what's your pitch to providers? Why would they want to work with you? These people left the insurance system. They left health plans. We have 40% of DPCs on HINT working with employers, but the number working with health plans really dwindles. So how can you get a lot of DPCs wanting to work with you and interested in you? Is that trust over time? What are you bringing to the table for them?
Can I make fun of you all a little bit if I also make fun of my dad? I think that's a pretty good trade. So my dad was a really good primary care doctor, and he ended up getting promoted because that's what they do to good doctors in HMOs. And they said, we want to promote you, but you dress horribly, and you need to go put on some nicer clothes. And he didn't own any nicer clothes, so my mom took him to Macy's, and he complained the whole time. And she said that when he thought she wasn't looking, he was checking himself out in the mirror and kind of liked how he looked in his new duds because he'd never bought nice clothes for himself. And I always think about my dad, and I know some of you are way more sophisticated than that. Dr. Aiken, way more sophisticated. Most of you I've talked to more sophisticated than my father. But you don't want to do marketing. Ugh. Like you're doing patient care, and that's what my dad always loved, and that was why he struggled in the system that he was in, and I wish he'd had DPC. So, for us, I want to send you members. When your members need care outside of the primary care setting, if it's an emergency, they should go to the nearest hospital, and we're going to cover the bill because that's what insurance has to do. And when there's non-emergency care, we're going to build a network around you with you at the center so you can go get high-value specialty care that's really good quality. And if you want to talk about why we make the referrals we make or you want to look at our data, we'll share it. And for us, that's been a pretty good pitch because we're not trying to change how you practice. There's no reporting requirement, no nothing. And if anything, I've heard more kind of when you come into my area, and that part seems to be working for people.
Yeah, honestly, I think I don't have the dad story, but pretty similar in terms of...
You can borrow my dad.
Really similar in terms of we want to, working with us obviously involves some administrative conversation, but we don't want to add in terms of administrative burden. We want to, again, we'll surface the data in terms of if you need any perspective on what downstream referral is, but we'll also, as Nick mentioned, we want to understand sort of where you want to send members to because we don't want to get in the way of that. And so I think for us also, Nick too, in terms of we're not a bolt-on. We're not working outside of the plan. This is baked into the benefit design. I think incentives are really aligned. So it has been a conversation that we've seen really effective. I think one conversation that has come up is that how can we, in terms of relationships with the employers, sometimes DPCs want to hold that relationship. We're there to actually aggregate so you don't have to contract with a million different employers. You can work through us and we can help standardize and scale that so that you get more members, you don't spend, or patients, you don't spend, again, that time marketing and trying to acquire customers. We're there to help funnel people to you because the belief in direct primary care, I think, is, again, baked into everything that the plan is built around.
Yeah. And is it right that in both of your plans, every member has to have a DPC or a primary care doctor?
It's the primary method for both of our plans.
Yeah.
Both of us have oh my God, if you got that one guy on your team that says, under no circumstances could I ever, see anybody other than this, we'll just overcharge that guy for his health care.
So it's not that you're adding this onto your plans. This is the core of your plan.
It's the core of the plan.
Yeah.
It's everything.
I think, Olivia, you nailed it. We're moving from a world of like bolted on, you're sidestepping insurance to what if you could actually fold it in a meaningful way? In many ways, can we think about also bringing primary care to a place where you're not just making, in a fee-for-service world, not that that's what we're doing here, $150 a visit, but taking part of that premium, taking part of that downstream risk in a meaningful way. And I think that's how you take practices and say, this is a massive economic tidal shift in what it means to be a primary care doc, frankly.
And Cedric, how does your platform enable new startups, new health plans who want to put DPC at the core to do that?
Yeah, so running a health plan, we started, customer number one at Flume Health was the Flume Health plan. So we worked with employers in 38 states, thousands of members paying out tens of millions of dollars of claims a year. And we saw firsthand, like, if you do the administrative job well, nobody notices. If you do it poorly, you get fired, you get fined, and everything goes wrong. So it's truly a commodity utility layer that has to be done correctly. The industry today is reliant on effectively people with sticky notes remembering to share files at the first of every month. That's how, surprise, surprise, the back end of your health plan runs, okay? So we looked at this as an opportunity to say, let's build it, systematize it, and build it highly scalably one time, and make it developer first, so anybody can come to Flume and build a health plan and abstract all of this work away so you never have to think about it. Being good, being the world's greatest plan, whether it's pop-in, it's decent, or it's another plan that's being thought about or conceived in this room right now, you don't get any points for just getting the administration right. You get points for really great member experience, a really great care model, a benefit design that wraps around that model. And so Flume very much slips into the back end and saying, we want the best ideas to get to market very quickly, very affordably, and typically it takes anywhere from 3 to 6 months to go from concept to a live health plan on Flume.
Yeah, so you're empowering that good idea that they have here.
That's right.
Awesome. So, what are some of the expectations that you put on providers in terms of data? Look, Olivia, you mentioned you give data to providers. So, are there things that they have to report back to you? How are you showing the value of this embedded primary care in your plan?
In terms of the data that we get back from them, it's really just what does utilization look like so that we can help paint the picture around what is DPC delivering in terms of ultimate savings and I think avoided utilization in terms of where we don't want members to go.
Yeah.
We also, so in addition to sending data around what could the referral network look like, we also send claims data so that the DPC has a more comprehensive picture around what is the person doing outside of their four walls. And so for us, it's really, we don't want to silo data. We really want to use it. And as the TPA, as we're understanding sort of where people are going and how they're utilizing care more broadly beyond TPC, how can we use that to help our DPC partners actually create even a better member experience for their patients?
We don't ask for visit or utilization data. We ask for your phone number so that I can call you and ask you how it's going.
Right. So I want to get we've seen the early adopter curve. We saw it, I think, yesterday, but you've all seen it because you're moving up the stage, that curve of DPC becoming more mainstream. I think for the innovative health plans, are you on the curve yet? Like you're just kind of taking the first steps onto the curve, but you're at the bleeding edge. You're doing the really, really cool stuff. So what do you see like if you could predict what's going to happen, like what we're going to be talking about at Hint Summit 2024 or 2026, what's going to happen with innovative health plans next?
I'm not good at predictions. I don't even know what AI is. I was real lost yesterday. But I can tell you what Decent's going to do. And this is pretty exciting. So one of the real proof points, and I hope you all are feeling this because I know it takes time to build this movement into what you all want it to be. I think it's amazing that One Medical's here and that without any weirdness, they're literally adopting and building the traditional DPC model. That's because it works. It's really, really awesome. And because they're going and they're doing real, pure DPC, we get to work with them. So Decent's going to be partnering with One Medical exclusively in the practices that are using a true DPC model. Our beginning and our heart and our future is with independent direct primary care doctors. We don't employ doctors. We want to work with you. We will be in as many as 47 states next year, and I've never been able to say this outside my team until right now. We've been banging our heads in Texas for the last 4 years. And we are on track to be in as many as 47 states. So if you haven't come found me or anybody from my team, Decent Team, I think I see some of you there, raise your hands. It's a nice team. Come on over and let us scan your card, because we'd love to work with you when we come to your geography. We're gonna have all the big ones except New York pretty soon, and we'll get there eventually as well. But the prediction for me is we're gonna try to help you grow.
Great.
What are the 3 states?
New York and 2 small states.
Cedric, what do you think? What's coming next?
I'll make a slight prediction. I don't know the shape and texture, but there were about 24, what do we call it, like new health plans. We call them challenger health plans that were announced last year. And so far in 2022, it just seems like that's accelerating. What I think is happening right now, and what we believe is happening, is effectively this opportunity to say, you are my patient. Do you want to become my member? Do you want to become part of this health plan? And we believe that there's a movement going from everyone is basically picking between bronze, silver, gold of a one-size-fits-none health plan to something that starts to feel much more personalized. There are doctors in this room who understand their patients better than any large BUCA ever will, whether that's a minority demographic group, it's a certain geography that's underserved, it could be certain chronic conditions that are totally underserved, it could be an industry, it could be certain types of workers that are just underserved. And somebody is saying, I understand what these people need, I'm gonna build a health plan for them. And so what we're predicting is very niche, long tail health plans that are very well understood. They have a care model right at the center, and you're gonna get something in a few years that feels like personalized plans. And when you're signing up for your benefits, you're not picking, do I want the PPO bronze or do I want the PPO silver? You're gonna say, I have epilepsy, there's an epileptic health plan, and it makes everything I need to do cheaper and easier for me, and I'm gonna pick that. And it's gonna be a really, really cool moment, and it's right around the corner. That's my prediction.
Yeah. Olivia, how about you?
So I'm going to pick from pieces of both of those. So I think for us, again, a horse in this race, but I think the proliferation and leverage, like, use of DPC, I think we're hoping that that's pervasive for people in terms of what that looks like. And I think in terms of, Cedric, what you talked about, for us, personalized health plan is definitely, I think, exactly what we talk about. I don't know if we actually believe that it's going to be a bunch of niche health plans, but for us, a plan that actually is built for you and something that you are going to use as a person is something that we totally rally around.
That's great. So unlike most of my life, I'm actually on time. So we have a couple minutes for parting thoughts. Is there anything that you want DPCs to know about you? What I would say about them is they're the real deal. They know DPC. Like, read the contract, but trust them. So what would you add?
I don't really need positive feedback because I won't listen to you. And so just tell us where we're screwing it up. We can't do anything unless we get it right with your help. And we've made some progress in the last few years at Decent. I want to give Poppins a ton of credit because they came out and just much smarter from the beginning on a lot of stuff than I was. But all of this stuff depends on clear, open communication so we don't screw it up. So please email me at nick@decent.com. Come talk to me. My phone number is easy to find on the internet. And help us get it right, please.
All right.
Well, I mean, Nick, we learned from those coming before us, so thank you for helping us with those lessons. But yeah, I think we'd love to expand. We have a couple of DPC partners now, but we really, really want to expand that number. And so figuring out how do we work with you? What's the best way? Would love to engage in those conversations and figure out how we can increase the number of DPC partners that we have.
Yeah, the only thing I'll say is if you've ever thought of either saying, look, we're now independent, we are delivering more downstream value than we're capturing today, which is what we hear from a lot of primary care doctors. One of the ways you can capture that is by partnering closer with an insurer, and especially these new age insurers like Decent, like Poppin, or building your own health plan. If you have a conception of how you want to manage an end-to-end member experience, not just in your four walls, but outside as well, you should think about building a health plan or getting in a group and doing so. I think I'm kind of preaching my book here in a sense, but I think that that's the future, and that's what lights me up, is providers being in charge of the next generation of health insurance companies, and then also being able to take risk against that and multiply their earnings. Because if you are right and you're actually delivering value, you should be able to build a really big business on top of that. And you are, for the first time, seeing really aligned incentives between better outcomes and basically higher earnings, which I believe healthcare has not in many ways been capitalist enough. We haven't had enough competitors. We have new competitors entering the market, and we're finally entering a space where we're seeing the alignment of incentives with high upside, with high value being created for individual patients. And that's what excites me.
Awesome.
This movement is beautiful, and it's not growing fast enough. And we feel it up here just like you feel it. And so that's what we're here to help with.
Thanks. So my prediction is they're going to do great, and then you're going to have Blue Cross and Aetna and Cigna calling you to be part of their DPC health plans. Don't take that call, or at least read the contract even more carefully. So thank you to my panel. You did great. Appreciate all your thoughts. And find these guys will be at Red Rocks tonight, so you can scan your card there.
Thank you, Beth.
You're welcome.
Yeah.
Thank you.